So if we can redesign the system, and Judi, I love that you poked on the fact that we've got a looming thing coming, which is the bankruptcy of the Medicare system. And so we're going to have to fix it eventually. Next year is going to be really tough to be a hospital administrator. It gives the vision that we're revolving around the hospital universe, and it feels like the solar system is shifting as we speak.
Annette and I both talked about this rate increase doesn't align at all with current reality.
No.
It's like it couldn't align less.
You can rail against the world, you can rail against gravity, but you're still stuck to the earth. Gravity ruled that situation, and there's a couple of situations that we could get so animated and just upset about. It's better to put our energy in what are the problems that we can solve as we go forward. It was the Venn diagram, and I think we're going to have to go back there as a country because we can't, because the other way is not going to work. This is the game that we're playing, and these are the rules. And instead of kind of bitching about the rules, let's actually do our best job within it and put our energy on that on a day-to-day basis, because that's what our patients and families deserve.
Know what's happening. Change is going to happen, and we can either be part of it and help inform it, or we can sit by the wayside and let it happen to us.
And now our TCN Talks host, Chris Como.
Hello and welcome to TCN Talks. I'm excited today. I'm always excited, but I'm really excited because I just have two giants with me. Giants in terms of just, I get to meet so many incredible people in this podcast, but these are two people I've admired for so long. I just could just pinch myself many years just to think that I've got Judi Lund Person and Annette Kiser on a podcast again. So welcome, ladies. It's good to have both of you.
It's so good to be here.
It is good to be here. Thank you.
Yep. So Annette Kiser is the Chief Compliance Officer with Teleios. Again, I'm privileged. Not only do I get to have Annette on a podcast, I get to work with her. And then Judi Lund Person is the principal of Lund Person Associates. And many of us know that Judi worked for many, many years for NHPCO. Just truly two of the most amazing compliance experts in the country. And now I get to call them both friends and get to have them on this podcast and share them with all of you. And of course, this is an interesting time of the year. I always say that I'm a bit of a geek. I'm always reading stuff, but I have to admit, hopefully Annette and Judi will own this. They're a bit of a geek when it comes to the wage index.
Judy's the geek when it comes to the wage index.
Good point. Actually, exactly. And I think she'll own it too.
Oh, I definitely will. Yes.
But I use a different G word, and that is guru.
Oh,
yeah. Well said, Annette. Very well cleaned up. She is the guru. So definitely got the two right people to talk about the wage index. It's always an index. It's always an interesting time of the year. So ladies, shall we just jump in? Because there's a whole lot to talk about.
Sure.
All right. So the FY 2026 final rate increase. Wow. 2.6%. I say wow, and then also gosh, compared to inflation. Right. But it is higher than the proposed rule. So how does CMS determine the amount of the rate increase? And maybe, is there anything hospices can do to increase the percentage rate increase? Like, is there anything you can do to advocate? And maybe final one question I'll add to that too. What about the MedPAC recommendation of no increase? And maybe you guys will kind of take all that and take it from there.
Sure. So I think the first thing is the rate increases for hospice and for some other Medicare providers is based on hospital data. So the proposed rule, which was published in the early part of April, had a 2.4% rate increase. And then one more quarter of data came in for hospitals, and it pushed the rate increase for hospice and for every other provider type that is in the spring season of payments. It pushed it up just slightly. So we are at 2.6%. And I think we would all argue that 2.6 is just not very much. And it's certainly, to your point, Chris, is not anywhere close to what we're dealing with inflation. So as we're thinking about what hospices could do to increase the percentage rate, I'm really sorry to report there is nothing. So that's I think the first thing for us to say. And the statutory requirement for the rate increase is long standing. And I guess in some ways the statutory requirement for the rate increase is some protection, maybe is kind of too strong a word perhaps, but it is something where the Congress has said through statute that here is how the calculation should work, and here is how and there will be a rate increase. Over the years, I've gotten a lot of questions about MedPAC. The Medicare Payment Advisory Commission has a hospice chapter every March, and for the last couple of years, they have recommended no increase in the rates. Now, so when that comes out on March the 15th, then people call and say, well, wait a minute, we have a MedPAC recommendation. Does that mean we're not going to get a rate increase this year? No. It means that they are sending a message to the Congress that maybe we should be looking at this a little bit more closely. But it would take a change in the statute in order for a 0% increase to occur. So I think that's those are all the pieces of this that I think are really important for us to think about. And I wish I could say that a hospice or a group of hospices could change the rate. It is just not possible, I'm sorry to say.
Yeah. And maybe this doesn't help any much because I know, trying to run an organization in an inflationary environment, wage pressures, it's tough.
Right.
When we look internationally, many of the countries that have different healthcare systems from America, the prices are fixed at a national level. So this is not totally a US based thing. And unfortunately in healthcare, we're not running a restaurant. We're not running just a typical business. You're not Amazon, right. And we can't actually control our revenue. It's one of the downsides of being part of healthcare and makes it difficult. But again, it's not only an American thing. I think recently I was reading an article about Japan because their baby boomers are ahead of ours, and minute 1% increases, et cetera, because their inflationary pressures or volume pressures are even worse than ours, because they're 10 years ahead of ours.
Sure.
Well, Judi and Annette, so every 10 years, CMS uses the census to determine what counties fall into each CBSA, the core-based statistical area or rural area. And they're using Census Bureau population and journey to work data. Last year for FY 2025, CMS applied those changes to the Hospice Wage Index. So why do some counties have changes to their CBSA or their rural area? And can we do anything about that? It feels like so many people are like, I feel like I'm having something done to me. Can we do something about that?
Right. So I want to start by using the U.S. Census Bureau term "journey to work." I think that is just such an interesting phrase, but it is the Census Bureau's measure of where do people go that live in a county, where do they go to work? So it's commuting patterns, really. And so when you have that, and I will take Montgomery County, Maryland, right here in the DC area as a really, really good example. So Montgomery County, Maryland is on the other side of the Potomac River from Virginia, and it is in the core-based statistical area with Frederick, Maryland. It is not in the Washington, D.C. metropolitan area. And for more than 10 years, probably 12 to 14 years, the Medicare providers in Montgomery County have begged and pleaded and petitioned and gone to Congress and all of that to see if they could move their connection, their assignment of a CBSA to the Washington, D.C. metropolitan area, which is very significantly higher wage index. And nothing worked. Not one single thing worked. No regulatory pressure, no pressure from members of Congress. This is the Census Bureau. This is how it goes. And every 10 years. And so we hoped, I think, as we were working in the last few years with Montgomery County, we hoped that the 2020 census would show a different commuting pattern into DC or into one of the areas, one of the counties that are in the Washington, D.C. metro area. That did not happen. So all of that is a long-winded way to say that the chances of changing your CBSA are very, 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 very small. I don't want to say zero, but I think it is as close to zero as really you can get.
And if I'm not mistaken, Judi, hospitals have a way to they can petition or something.
Oh yes, they sure do.
But there is no mechanism for that in our world.
No. And hospitals can say, well, I have the same pressure as my neighbor next in the adjacent county who is in a metropolitan area. And so therefore I should get that wage index too. Hospitals are the only Medicare provider that has that opportunity. And there is no other provider, post-acute care or other, LTACs or others who have that as an option. So, as we think about kind of all the changes that could be possible to the wage index, both for hospice and for more broadly for others, I think that certainly should be something we talk about, but I think it's been in place for such a long time. And Annette and I were thinking about this the other day, that when I still lived in North Carolina, which is now more than 20 years ago, this was a problem in counties adjacent to Charlotte. So, it's been around for a really long time, and the hospital lobby was a very successful one to get this to work and to keep it in there. But it doesn't apply to anyone else.
We don't understand the infinite wisdom that happens behind these things, because a hospice adjacent to, a hospital in a metropolitan area or a hospice in a metropolitan area has the same expenses. And so if the logic is the hospitals get to use that, why shouldn't any provider? So I think you're right, Judi. It's just a matter of continuing to fight. And if it were tied just to a certain thing, not to the census or something like that, it would make a difference. And I think even now people aren't as careful about filling out their census forms that come to them as what they used to. And some people don't want to share that information.
Right.
And so you have to wonder even how accurate some of that census data is.
Well, then I want to throw out another part of this puzzle. So we're looking at the 2020, the current data is the 2020 census. Now, we can think back and say, what was happening in 2020? Was anybody journeying to work? They were journeying from their kitchen to their home office. But so I am curious about whether that journey to work metric, the commuting metric, really is different because of COVID. So, I mean, it's just interesting to think about all the various pieces of this.
Well, and what's that going to look like in the 2030 census? Because a lot of people who were journeying no longer journey, and they've stayed at home.
Absolutely.
And so it's a very different workplace than what it was previously. So it'll be interesting. But unfortunately, that's 5 more years before they even collect that data.
Right. And 10 more years before we see it in any kind of impact on the wage index values. So
these are questions that Annette and Judi are getting all the time. So like they're listening to you guys. And when I said, let's do a podcast on the wage index, they said, I know exactly what we're going to talk about, because these are questions that they're getting frequently. So CMS implemented a calculation that would allow up to a 5% decrease in the wage index for a given metropolitan rural area, but no more. Why was that implemented, and why do some wage index values drop? What is that value based on? And does it help providers whose wage index value drops in a given year?
So, I mean, it's actually, we should cheer, because a 5% maximum decrease in the wage index is a really, really helpful protection. And I know some of the comments that came in on this year's proposed rule, people said, well, 5% is too much. I really want a wage index drop maximum of 2% or 3%. CMS did not go along with that, but what we saw before this 5% maximum adjustment, some counties or some CBSAs had wage index values that dropped like 10 or 12%. And I could tell you counties around the country for whom that was a horrible, horrible problem. Right. So we have, CMS has fixed that part of this, and the 5% maximum reduction is now permanent. And we'll see some adjustments. And the last year and this year both are a little wonky because of the Census Bureau and the changes in the CBSAs, and then we have the 5%. But I think it won't feel like if you're the one that got a 5% drop in your wage index, you'll be mad. You're mad. I know. I'm mad too for you. But I think at the same time, it's not 10%. It's not what we saw before this 5%. I mean, and One of them in the Ohio, West Virginia, CBSA, 12%, and very, very low wage index every single year that it came out. So, I think that's a really good one. And um, what I think it does for providers is it doesn't give 100% stability, because you still have that drop, but it does mean it's not going to be as catastrophic as we've seen before this happened.
You can at least budget and know that that's
Right.
the max that it's going to
Right.
decrease.
Yeah.
It's so interesting. I'm sitting there processing. I talked to my dad actually before inflation hit, because I don't know, we were wargaming scenarios. I think that's what it was at one of our visioneering meetings. And I just remember as a kid growing up during the whole Carter administration and remembering the long lines of gas and just these crazy inflationary times, and I asked my dad, I'm like, what did you guys do about wages? And it's like, you pretty much froze them because just all the inflation or you were trying to keep up with it. And I said, well, what happened on the back end? Did you then take the wages back down once you went up to keep up with the inflation? And did you go back down? And he said, no, you never go back down. And it's like, well, so I'm processing what you're saying and put myself in the shoes of those hospices.
Right.
I don't know of a market where then you decrease people's wages, but yet that's 60, 75% of your total cost.
Right,
I mean,
sure.
that is a tough way to run an organization.
Absolutely.
That's a great analogy, Chris.
Yep.
Well, let's talk then about, so I know you get a lot of questions about this one. What is up with the labor and it wasn't framed in that way. I'm interpreting, but what are the labor and non-labor portions of the rates, and how is that percentage calculated?
So one of the things that I recently spent a good amount of time with a hospice who said, well, where does it say, where do these percentages come from? Where does it say what the percentage is? And so what I want to start with is back in 2022, when we were doing some rebasing of the rates, they also rebased the percentage of the total rate that is labor and then the percentage that is non-labor. So let's just take for an example, and you'll see on the slide that we posted for you here, that for the routine home care rate, 1 to 60 days and 61 days plus, the wage component is 66% of the rate. Then you see the SIA, also the continuous home care hourly rate, and continuous home care, 75% is wage component. If you start to think about what the philosophy is behind this, it's like most of what we do with that level of care is human, is people, is staffing. It's not, we don't have buildings, and that's when you start then to look at the inpatient respite, which is at 61%, and then GIP, which is at 63%. That's different because there are facility issues in there. So when you are starting to look at how do you figure out the rate, the percentages are straight national, and they've been this way for several years. They were adjusted a while in 2022. So then you say, okay, well, how do you figure out what my rate is, what my rate as a hospice is? And that way you can start to see, and I was trying to color code it just a little bit. So if you look at routine home care, 1 to 60 days, and you say, okay, the national final rate, $230.83 for FY26. 66% of that is the wage component, or that purple box on the slide that you see now is, the purple box says $152, and my calculation over many years where I was never have a rounding error. So it's $152 and 34.8 cents. So you take that is the part that is connected to the wage index. So you take the wage index for a county times this 152,348. That's the wage component. And then you add the non-wage component, or the blue column, where it's 34% or $78.482. So that's the wage index value. And this is where then we start to say, okay, this 5% reduction is really important, because you were looking at 2/3 of your rate being connected to that wage index. And so I think that's a piece of this that we want to always keep in mind. So I'm hopeful that the chart and the calculation gives you a little bit of a sense of, you can look at this for yourself. I know Teleios has provided rate charts for lots of states where Teleios has providers, but you can also figure this for yourself if you look at your wage index and then look at these calculations. So the formula in the two little gray boxes at the bottom tells you how to make that happen. So I feel like it's not a mystery if you know where all the stuff comes from, and that's probably the first thing is, you're digging. Even I, every year I'm like, okay, did the percentages change? And it's not in a table anywhere in the final rule. It's in narrative in one of the paragraphs. I don't remember what page now, but it's like, okay, why is this so hard to find? But anyway, once you find it and you know what you're looking for, then that you can really make all these calculations.
Well, that wonderful chart that you provided, Judi, we're going to actually put that in the show notes in case, because we have listeners that don't actually watch it. But if those that are watching can see it, and then we'll put it in the show notes. And Judi, not to chase this rabbit too far, but that labor portion and then the wage index, the ultimate headwaters of that, right, is hospital cost reports, and it's like 3 years trailing. Is that correct? Or is it not 3? Is it 2?
It might. Well, there's some part of it that's 2, and then there's some part of it that's 4. So it's at least 2 years, and it could be more than 3. But I think that is one of the biggest conversations right now. So if we're thinking about what could we do to, well, let me start a different way. So we've got every provider type in Medicare. So that's not just hospice, not just home health. Every single provider type is dependent on this hospital cost report data. So when you go down that path, it's like it affects everybody. It affects every single provider that receives Medicare dollars. So MedPAC in the last couple of years has come out with a recommendation that says, what if we took the wage values and assign the occupational categories for all employers, not just hospitals, but for all employers? And what if we used that data to base the wage index values on? So I love that idea, and there is certainly some activity this fall with a group of hospice leaders who are meeting with CMS and Apt Associates, their contractor, to start to think about changes to the wage index. We say that, we get all excited, and then we go, okay, how long is this going to take? And it is
right.
ages and ages and years before we can actually make this switch. But I think, it's there is a lot of, this is old school when most care was provided in hospitals. So it's a logical thing to use for that. But now most care is provided at home. So how do we adjust the wage index values to really meet the new reality?
Yeah, I think you said that incredibly well, because it does feel like we're at that sea change. More and more baby boomers are becoming those we're serving, and the future of healthcare is in the home.
Yeah,
and so it feels, and you think about the hospital business models are very challenged. Feels like it's challenged everywhere in healthcare, but boy, next year it's going to be really tough to be a hospital administrator. And you think they're a service-based business. Yes, they have costs, but their wage component is huge. And if you only have so many levers to pull, and you've got the Medicaid deducts, all other sorts of interesting payer challenges they're navigating, then labor is going to be impacted.
Right.
So it's going to be really difficult to be hitched to that wagon going into the future.
Yeah.
Well, and that's why we have to make sure that we stay engaged and we help our members stay engaged and have a voice. And when someone says, let's model a change, then we take that seriously and look at it and see what that would do to our rates and to our bottom line. And we share that information so that we are helping inform models that are being floated around out there right now.
Very well said, Annette.
Yeah, and Annette, the other piece of it that I think this is the time when, if you will, non-hospital providers need to band together. So this is post-acute care providers of all types, home health, nursing homes, LTACs, long-term care, acute care hospitals, IRFs, or inpatient rehab facilities. I'm sorry, I'm slipping into my acronyms, but we should band together with others who are Medicare providers as well, because I think we will make a lot of headway if we're together. And I don't want to minimize how important that is.
Power in numbers.
Yeah. Absolutely.
Yeah. Even I've had people push back on me, and I've tried to get away from using the word post-acute because it's framed based upon the acute. And so it's really care in the home. I've heard pre-acute, but then it's still kind of, tied to it gives the vision that we're revolving around the hospital universe, and it feels like the solar system is shifting as we speak.
Right. And very, very good. I mean, if we have that visual of everything is centered around the hospital, but now it's not, I think that's a really good visual.
Which those are always interesting in tough times.
Yeah.
That old Chinese, may you live in interesting times. Boy, that's really true for us.
Absolutely.
All right. So here's another question. How do the finalized payment rate adjustments align with or diverge from the needs and realities hospices are facing today, especially in the workforce, inflation, the never-ending audits? And then, there's so much that we've talked about recently, and a lot of our podcasts related to this. As we've kind of dug into this, we talked about it when the pre-wage index came out. So I'd love to hear you guys answer that one.
Well, Annette and I both talked about this rate increase doesn't align at all with current realities. No. It's like it couldn't align less. Maybe it could if we were getting a decrease rather than an increase, or we got nothing. That would be worse. But I think I think that this is another piece of the outmoded or outdated kind of rate increase process. So at the same time, then if we go to current realities and we say, how is that going to work with the Medicare budget, the Medicare trust fund, and all of that, I think we've got some really hard struggles, I think, with how much it costs to deliver care, and how can we do things that will make care more efficient. I think that's another piece of this.
Well, and doing a better job of controlling what we have some control over, that hospices need to be thinking about increasing their medication budget as much as 10%. And when we think about we got a 2% increase and meds might go up 8-10%, and then we know supplies, and just think about what happens when you go to the grocery store. Everything's increasing. And so what can we control and better manage versus what we don't have as much control over? And to some extent, we can control even medications from the standpoint of being judicious with our reviews and using those medications that are more cost effective. But it's really thinking smarter and paying attention to how do we manage this better.
Absolutely.
I love that you said that, Annette, about what you can control. I feel like there's such wisdom for our time. Stephen Covey wrote about this many years ago. He said, you can live all of your life. You have one of two walls. On one wall is that which I can control, that which I can problem solve, and ask myself, what is the problem to be solved here? The other wall is that which I cannot control. It's a principle. And I know and I love the way Judi has framed a lot of her answers. Some of these are principles. Right. You can rail against the world. You can rail against gravity, but you're still stuck to the earth. I went to dunk a basketball when I was in high school. I could not just float above the earth. Gravity ruled that situation. And there's a couple of situations that we could get so animated and just upset about it. It's better to put our energy in what are the problems that we can solve as we go forward. Now, I'm one of those that my mom always said I'd sit there and go, why? And so we had 2 podcasts this year, one with T.R. Reid, The Healing of America. I think he's got some great wisdom on how we redesign the American healthcare system. I brought someone who's a little bit more free market thinking, Rita Numeroff. We didn't get as much as where I wanted to, which is like, hey, if you were the queen for the day, so we're going to do a part 2. And it's basically she's a queen for a day. And my theory is that the Venn diagram between both of those podcasts that's the wisdom, because we're an American country that's always been divided, but we've always had wise people in Washington, D.C. that ruled from the middle. In other words, it was the Venn diagram. And I think we're going to have to go back there as a country because we can't, because the other way is not going to work.
Right.
And there's plenty of illustrations in history where that's the case. So what is the middle? What are the true solutions? So if we can redesign the system, and Judi, I love that you poked on the fact that we've got a looming thing coming, which is the bankruptcy of the Medicare system. And so we're going to have to fix it eventually. So we're going to do some more podcasts trying to at least create some discussion around how do you fix that system. In the meantime, this is the game that we're playing, and these are the rules. And instead of kind of bitching about the rules, let's actually do our best job within it and put our energy on that on a day-to-day basis, because that's what our patients and families deserve.
Couldn't have said it better, Chris.
All right, good deal. Well, here's another one. Speaking of the rules, why is there that aggregate cap thing, and what does it do, and why do we care? And when the cap amount is announced, what is it? What is it that year for?
Is going to be $35,361.44, which is basically taking the fiscal year 2025 cap amount, increasing it by the 2.6%. So it's easy to look at that calculation. But the cap came about way back when, because hospice is supposed to be a cost-effective model. It's not supposed to cost more, so it's easy to look at that calculation. But the cap came about way back when, because hospice is supposed to be a cost-effective model. It's not supposed to cost more to provide hospice care than it costs for the more conventional medical care for the same period. And we know from some of the studies that have been published that hospice does save money, and they want to make sure it stays there. A way that's going to allow them to have financial gain. And we know a lot of focus on profit margins, and there are hospices that go over cap. Unfortunately, some do it, knowing that they're going to pay something back, but feel that they make more than is needed. But it really is about keeping hospice as a cost-effective model and it not being a money-making business. And there's some shift away from some of that, and it's why it's gotten us into some of the concerns around fraud and abuse and that kind of focus. And at this point, the cap is what it is. That could change at some point in time, but it is something that we all need to pay attention to.
Thank you to our TCN Talk sponsor, Dragonfly Health. Dragonfly Health is also the title sponsor for Leadership Immersion courses. Dragonfly Health is a leading care-at-home data, technology, and service platform. With a 20-year history, Dragonfly Health uses advanced technology and robust analytics to manage durable medical equipment and pharmaceutical services as part of a single efficient solution for caregivers, patients, and their families. The company serves millions of patients annually across all 50 states. Thank you, Dragonfly Health, for all the great work that you do.
Just to add one thing to that, Annette, and this is an aggregate cap. So if you say, oh my gosh, Susie Smith, my patient who was with us for, 400 days, is going, we got paid way more than what this 35,000 and some change is. But that's why it's the aggregate. So It's like, let's say you had 100 patients last year, or 100 patients, and you're applying the cap amount to that. So it's 100 patients times this cap amount gives you the maximum amount of dollars you can get from Medicare for your patients. And if you go over that, then you have to pay the overage back. And sometimes I just think, starting with a really simple calculation like 100 patients times the cap, and that's how much money I have to spend. And it's like the aggregate. It's not every patient we have to spend this, and that's I think a confusion.
Well, that's very important to mention that aggregate piece because it makes a big difference. It's not, 30,000 left over from that patient, I get to keep it. Well, not if you spend 50,000 for the next patient.
Right, exactly.
I've seen, and I'm thinking about people I've seen go over the cap. I've seen kind of two flavors. I'd like you to push back, and especially you, Judi, because you've seen so many different just pockets throughout the country. Generally, when you're going over the cap, in most cases, we've done a lot of discoveries. Those programs are really admitting chronically ill patients, not terminally ill patients. So they're running a chronically ill program. That's why they're hitting that cap. And so the other type I've seen, though, is more rural programs that they don't have a robust healthcare system, not a good primary care base. So you may not have the clinical sophistication for that identification. So I don't think they're necessarily trying to do the wrong thing, but then it's bringing to their attention about the cap. Does that kind of stratification fit for you, or have you seen a whole bunch more flavors?
Well, I think there are a lot of flavors, but I think from my perspective, the cap and its application is 100% connected to your admission policies. So, for
recertification.
That's right. And for all those patients that you say, I think they're eligible, if you're doing a red, yellow, green, they're yellow, they're not green, they're not 100%, but they're not absolutely not ineligible. Then I think we have patients for whom the disease process is slower, and so you have a longer stay because the disease process is slower. It's not it just is. It's not a bad or a good. It just is. But I think for that group of hospices that are admitting patients a little bit earlier than maybe others would, or maybe even best practices, I think that's a piece of it. I'm always struck by a conversation I had with a hospice provider several years ago, and she was really mad because she had a $6 million cap payback.
Ooh.
And so I'm talking to her, and I'm trying to have this completely no reaction on my face, nothing like that. And she sits up very proudly in her chair, and she says, well, our average length of stay is 333 days. And I'm trying really hard not to react at all. And I said, okay, so, what does your physician do you look at the face-to-face? Do you do the recertifications? Oh, yes, our physician says that these patients are all eligible. And I said, okay, so tell me a little bit about the range. And she says, well, we have lots of patients who've been on our service for 5 to 7 years. Well, so now you're seeing that. And then she describes her service area as very rural. They're really the only healthcare provider besides the hospital. So I feel bad. I mean, these patients need help. They might not need hospice. So that's kind of where I go. And I remember this woman every day when I talk about the cap.
I'm so glad I asked you that. That's actually a great response. All right. So the wage index not only has wage stuff, it has wage adjacent things. And so there are 2 regulatory changes finalized in the FY 2026 wage index final rule. What are they, and were there some new requirements?
Well, so we have 2 pieces to that. One is around admission to hospice care, and one is around the hospice face-to-face encounter. And these are actually good changes that CMS has made. It's not a new requirement. It actually loosens things in both aspects. When it comes to admission to hospice care, we've had some misalignment. And the regulation at 418.25 says admission to hospice care is only on the recommendation of the medical director or the physician designee, which meant we shouldn't have the IDG physician doing that approval of the admission. And so what CMS has done is now changing it so that everywhere we have the regulations is going to align to say that the hospice medical director or the physician designee or the physician member of the hospice interdisciplinary group can all do the admission to hospice care and the certification. And that makes everything align. So we don't have this concern where one person reads one piece and says, well, you let a doctor give approval who shouldn't have. Well, now it's all going to say the same thing. So hospices don't need to change anything from being more restrictive. If they've been restrictive, which a lot of hospices maybe didn't even realize that misalignment was there, but if they've been saying, well, we can't have that physician approve admission or be involved, then now they can say, okay, we can. So any hospice physician can do that admission. And then around the face-to-face, it was a matter of getting things back in alignment again because just the language, and I won't go into the technicalities of it, but when it comes to the attestation that the face-to-face visit was made, when it was made, and needing to have that, CMS has been so prescriptive, and it has to be here and it has to be above this and that. It could be a separate document. It could be part of the certification of terminal illness document, but now CMS is saying that it needs to be documented, but it could actually be part of the clinical visit note. It doesn't have to be a separate standalone identified as long as it has the components. I will say that this was something that they should have had in like 2011. They went way back. I'm not sure what brought that up, but at some point they went way back and they're like, oh, we forgot to put this in there. And so hospices that we work with didn't change. They've been doing it all along. They've had the real clarity around that attestation. I don't see them needing to do anything different now, and it's actually a good thing. So both of these, it's not usual that we can say CMS made a regulatory change and it's all good, but for both of these, I think they are good. Yeah. Would you say anything different, Judi?
No, I think these are great things, and these are small things. I mean,
right.
These are going to make life easier, but there is nothing big that is
right.
a problem here.
Okay. What about the hospice quality reporting program? Was there anything related to that?
Well, there's always hospice quality reporting things. As we know, there's this thing called HOPE that people are having to deal with.
I don't know what HOPE is.
I know. I have said many times, if I had $1 for every time I've said the word HOPE, not in response to the tool, but we hope the EMR vendors, we hope the this, we hope the that.
We hope it goes away.
Exactly. Well, so to that point, Chris, CMS has made it clear it is not going away. October 1st, 2025 is the confirmed start date for implementing HOPE. And if we look at the calendar and today's August 15th, then that means we have 6 weeks. Deadline for that and HARP is September 10th. So hospices have less than a month to do that. And I did actually hear just this morning, and I haven't even had a chance to mention this to Judi, that one of the hospices that's in the pilot program for HOPE with their EMR did successfully submit a test case to IKEYS just today.
Wonderful.
And so that's good. At this point, we don't know how when we start getting all the volume going into IKEYS, but at this point, the hospice was able to submit their HOPE data, and it worked. And so it's a lot in the next 6 weeks, but from that perspective, things are not changing. We're going to continue to have our CAPS, satisfaction surveys. We're going to continue to have our hospice visits in the last days of life, which comes from claims-based measures. We're also going to continue to have the Hospice Care Index. And so those pieces are not changing for fiscal year 2026. HIS, Hospice Item Set, is rolling into HOPE, and we'll continue then to have that. But CMS will have to collect the data. It's going to be a bit before they report that out there. And, we're there at that perspective. And so there's nothing new that's going to happen based on what was in the final rule this year, but there will be things that change and come.
Right.
Gotcha. Well, then you kind of is a good segue. Is the threshold change from HIS to HOPE? And what happens if a provider doesn't meet that threshold?
No, it has not changed. There is still the expectation that a hospice submits 90% of their HOPE records, 90% of their CAPS data. And it's imperative, because this is a total change, that everyone is really paying attention and making sure that they're having those successful submissions. And as soon as CMS gives the green light for other people to test, they need to test and make sure your EMR vendor is doing a good job of communicating that to you. And then we need to make sure that we're paying attention to those. CMS gives after every currently HIS to become HOPE after every submission the opportunity for a hospice to print a final validation report that says, we got it, your data came through, everything's good. Hospices that end up in the less than 90% are not always doing a good job with tracking their final validation reports, and then they end up in a problem. And what happens is, if they don't meet their expectation of the 90% submission, then in the applicable year, they will get a 4% reduction in their rates. And when you think about 4% of what your annual revenue is for Medicare, that is huge. And it's so critical to make sure, because HOPE is so different. It's going to involve a lot more submissions to CMS than what we've been having with HIS. A lot of attention to that has to happen, but it's not changing. Thankfully, there's no mention of going higher than 4%, but 4% is significant. We got a 2.6% rate increase. If you get the 4% reduction, you're already, still in the red.
Absolutely. Well, what should providers be doing to prepare for these future quality performance expectations?
Well, so I think it's a matter of, really thinking about what they're looking at, being informed, being involved, having a voice, and making sure that they're, paying attention to that, monitoring their own data. Don't wait until the provider preview report comes out. There'll be a new provider preview report in the next 2 weeks. Care Compare, the public site, will update in the next 2 weeks. Those all happened in August. But that data is old. Hospices need to know what is their current reality, and they need to be figuring out how to pull that from their EMR, from their claims data, and really tracking what they're doing. And then we're going to have future quality measures around HOPE. We have to do our symptom follow-up visit within 2 days for those patients who have symptom impact, moderate or severe, and CMS will be looking to see, did we do the 2-day follow-up with that symptom follow-up visit? So hospices need to be paying attention to their own internal data to make sure they're meeting those requirements.
All right. Well, all of this is kind of interesting because it tells you how CMS is thinking. So what do you think this rule tells us about where CMS's maybe long-term view is? What does the final rule tell us about where hospice policy might be heading? And does this tell us anything about maybe like program integrity, survey reform, or even maybe just maybe innovations in care models?
Right.
Judi, I'll let you take that one.
Yeah. It's something I love to think about. So I think over the years, when we get the proposed rule, until 2 years ago, we had a proposed rule that had a whole section on data trends, and that would give you could read it. So I read it so carefully to say, what are you saying? And what does this mean for our future? Now, 2 years ago, the data trend chapter went away from the proposed rule, and APT put out a hospice monitoring report that is published now each year in April on the CMS website. It's not the same. And so then I want us to think very specifically about this year, because you go, okay, there is not much you've heard. There's not much in this rule that is a change. So let's talk about the getting everything ready to get posted as a proposed rule in April. Meant that a lot of this work was done at the end of last year, the beginning of this year. And what happened at the beginning of this year? We have a new administration. We have a new Secretary of Health and Human Services, a new CMS administrator. And so from January 20th, sometime in February for some of it, we had people who needed to set a new course for the administration. And so there's not much in this one. Now, given that, and now we have these people in place, I think it'll be interesting to see how next year's proposed rule looks. The other thing I think we may depend on kind of reading the tea leaves just by looking at the rulemaking, but there are a lot of other things that CMS can do to communicate what's going on. So the QSOG and the Quality and Standards Operation Group, I think, is the acronym. It comes
Quality,
from the
Safety, and Oversight Group.
Oh,
they
sorry.
changed
See,
it a little bit for some reason.
I'm really off, but it comes from the Center for Clinical Standards and Quality, where our survey process is.
Right.
There are things we should be watching there. There are things that we should be looking at in terms of changes to the state operations manual. So there are some other things. There are things that the Center for Program Integrity is starting to put out. So it's not just rulemaking. It's really putting your ear to the ground and saying, okay, what is happening in all these different places that we need to pay attention to? I think that's part of the fun in the Judi Lund Person world. It really is fun, but for a lot of people, it's just trying to figure out where the information is. And then I think, as far as innovation is concerned, the Center for Medicare and Medicaid Innovation, CMMI, there are opportunities for hospices to take a look at some of those innovation models. And if I had to sort of say where I think we should be paying a lot of attention, it's what are the metrics inside some of those? Are we looking at in the guide model? What are we looking at in terms of bundling a per diem payment or unbundling a payment? What are the things that a hospice could do that really put them in a different place in their community, put them able to serve more people and all of that? So those are, I think, kind of all interesting things, but certainly the new administration will give us plenty to take a look at.
At the beginning of this year, we do the top news stories of the month with Corda Kastner, and we had Mark Cohen kind of carrying over from last year. We coined a term. It actually came from someone within TCM, but the predictably unpredictable year. It sounds like that's going to kind of carry over a little bit into next year, but I also hear in that, Judi, that we're going to probably have a sense of which way the windsock is generally blowing. And so do you think that we're going to wake up in April and read the preliminary wage index and be blown away, or are we going to have some pretty good indications ahead of time? Or is it just, I don't know.
Here is, let me just take one example, because I think this definitely could move us into next year's rulemaking. And that is the interoperability data kind of stuff that now there's a lot of focus on, a lot of push from Dr. Oz, a lot of push from RFK Jr. To really see if we can make data interoperability a goal. Now, how that plays for the hospice community, I think we could make a few assumptions about it, but I think that's going to be really, really key. The other thing I think that is like just the tip of the iceberg are some of the RFIs that CMS has been asking for. For instance, in this year's rule, we had an RFI on interoperability, but we also had an RFI on nutrition, wellness, and the third one, Annette, I can't ever remember. But anyway, no comment whatsoever in the final rule about these RFIs. So what does that mean for us? That means that something is cooking, but it's not quite ready for prime time. So those are just kind of things I think for us to watch. And I know many of us, when we wrote comments on the proposed rule, especially around these kind of new thinking about social determinants of health, and you're talking about wellness with a terminally ill, very, very sick Medicare population, you go, these two things don't fit together. Mm-hmm. So what does wellness mean? What does, how do we frame that so that we are thinking about the best possible experience for a Medicare beneficiary at the end of life? I don't know how that's all going to come together, but I think that's where we still have to be. I think this is a place for us to be creative too, and not sort of just take, this is, maybe it's in that, not on the principle, but on we can do something about this, and we can think about things that are very creative here. So
well, and continue to have a voice. I'm surprised when I read through the comments, because CMS in the final rule, CMS says X number of people commented on this, and there's so many things where there's only a couple, and it's like we needed more of a voice there. Now I recognize that when the associations comment, CMS counts it as one, and they're speaking for a volume, but we still need, again, back to that comment I made earlier, power in numbers. And we just need people to be involved and engaged.
So I want to go back to CMS counts it as one, because one of the things I think we should carry into the future as we're looking at kind of changes from the rulemaking process, and that is CMS counts every respondent as one. And so we should all be commenting. It's not just the association, the National Association or whatever. We can sign on to whatever letter is going from a national group, but we should all comment as well, because there are some things that are state specific or provider specific, and it is a way for us to have all of our voices heard.
Well, two thoughts, and I want to hear both you ladies' kind of final thoughts about maybe strategic actions given all this. But when I think about the chassis that is hope, Peter, Benjamin, and I have debated for a while, like, what are the true measures of, Peter said, here we are 30 years, do we really know what defines quality? Well, isn't hope going to be the chassis to push? What really defines quality, potentially? And I love at least some of the general things where, like, what matters most that we're asking in there, which leads me to my second point. Judi, I love that, outstanding question. We had a great discussion in the preliminary wage index about those RFIs, and it got me thinking. And lo and behold, we did a podcast with the John A. Hartford Foundation. And the 4 M's to me are very important. Like, that may be the answer to that whole wellness thing. Like, that's what it means in this world.
That's right.
In the serious illness and end of life, which the 4 M's are, for our listeners, go back and listen to that podcast: mentation, what matters most, mobility, and medication. It feels like that's a great framework, actually. Yeah. And what really hit me was the brilliance by which John A. Hartford came to the 4 M's. There were some brilliant people around that table and thinking about what matters to those that are aging as we go forward. So I think that 4 M's is something we need to keep pushing on.
Agree completely.
Good deal. Well, last question to you guys. Well, given all of this, what do you think maybe are 2, maybe 3 strategic actions every hospice should take based on this rule? I hesitate to say to stay ahead, but at least keep up, stay ahead of where things are going regulatory, financial, and clinically wise in 2026, and maybe positioning for beyond.
Sure.
Well, I think it's a lot of what we've already talked about with being engaged. Know what's happening. Change is going to happen, and we can either be part of it and help inform it, or we can sit by the wayside and let it happen to us. And I think we have too many times when we just let things happen to us, and we really need to be paying attention, being engaged within Teleios, within associations, within your own community, and working with those that you get referrals from, that you have patients who go to for care, and really understanding kind of what is going to change and what can we do about it. And back to what I said earlier around, in an earlier meeting today, what can we change? What can we impact? And, what do we just have to accept? But there's not a lot that we can't influence in some manner.
Totally agree. And I think the other piece of it is that don't be shy. And I would say don't be shy, and don't let caring for patients consume you so much that you kind of shut out all the other stuff that's going on, because there may be some really cool opportunities for something new, a workflow that might be different, that really, really makes a difference. And I'll just share a meeting I was in yesterday afternoon where we were talking about access and what does the data show about access to hospice by various racial and ethnic groups. And the guy who's done the research says, in the African American community, it may be the only hospice care that African American patient gets is GIP in the hospital and the last 2 days of life. Don't we want that care to be just as exceptional as the rest of our care when we have a lot longer to provide care to a patient? And it has really stuck with me.
That's a lot to think about.
It is a lot.
You do have those where they're admitted in the hospital and they die within hours or days, that is their sole impression of hospice.
And I also want to just stop and think just for a minute about our own. Now we have so many people that work in hospice that have also had hospice experiences, good and bad. And so when we are thinking about what can we do, it's like we need to also be thinking about what can we do so that more hospice is good, or the experience of hospice is good, and not so much bad.
Right.
And our colleagues who have had horrible experiences and wonderful experiences, and that is, I think, for me, that is a driver that keeps me both awake at night and going every day.
I love that. And I love that you're both going and are on the job.
Yep.
And thank you for taking the time to, because I know this is always a time of the year of digesting the wage index, and you guys just made it very digestible. We're going to you included a lot of links whenever we were getting ready for the show, so we're going to include those in the show notes. So thank you both.
Absolutely. Great to be with you, Chris.
Thank you.
Thank you.
I asked Judi and Annette to pick a quote, and they picked a John Wooden quote. Love John Wooden, and it's a great one to end the show with. Things work out best for those who make the best of how things work out. Thanks for listening to TCN Talks.